Good evening, and thank you all for joining us for another installment of our Ask the Doctor series. I'm Titania Bailey, president of Arc of Knowledge, Inc. We are a nonprofit organization that provides resources towards building and strengthening relationships between our youth and seniors. And as a part of our generational health and well-being initiative, Arc of Knowledge and Centerpoint Baptist Church have the pleasure of partnering with MedStar Health and their team of specialists to provide education and resources that promote better health practices. Our speaker for today is Tarana Nexzad, who is a cardiologist at MedStar Cardiology Associates in Brandywine. She is board certified in internal medicine, adult echocardiography, cardiovascular nuclear medicine, and board eligible in cardiovascular medicine. She also holds a registered physician in vascular interpretation certification. Dr. Nexzad focuses on risk stratification, prevention, and management of the full spectrum of cardiovascular conditions, including coronary artery, valvular, peripheral, arterial, and aortic diseases. Throughout her advanced training at Michigan State University, Dr. Nexzad was consistently recognized for her clinical skills and leadership strengths. She was named Chief Intern and Most Outstanding First-Year Resident, Hospital Chief Resident, and Cardiology Chief Fellow. As a doctor of osteopathic medicine, she is trained to emphasize patient-focused care while offering guideline-based treatment plans. One of her favorite things about her work is the opportunity for patient advocacy and patient education. She practices empathy and active listening while learning about each patient's life. She aims to help them fully understand their disease, their diagnosis, and how they can reduce their risk of adverse events. So without further ado, please welcome Dr. Nexzad.
Thank you. I appreciate that introduction. So my name is Dr. Nexzad. My name is Tarana. I'm a general cardiologist who works primarily out of the MedStar Brandywine office in Maryland. And I also cover Southern Maryland Hospital occasionally. So yeah, that's all I have for introduction. I'm more than happy to answer any questions.
So if our participants would like, they can take themselves off of mute to ask Dr. Nexzad any questions they may have regarding cardiology practices, anything that you may have on maintaining heart health, guidelines for heart healthy lifestyle, and any other things that you may be experiencing regarding heart health.
I have a couple of questions on cholesterol, if that would be okay.
Absolutely. Let's go.
Okay, so I will go ahead and right off the bat tell you for the last 3 months, I've been on a carnivore diet, which is probably the last thing you want to hear as a cardiologist.
That's a little bit hurtful to hear. Depends what you mean by that.
Right. So before I was on ketogenic diet, before that, a standard American diet, and my cholesterol numbers has been elevated, we'll say. With the carnivore diet, the thing that I'm running into is I have insanely high LDLP and LDL numbers. And my small LDL is high.
Okay.
But my LDL particle size is big, large, and buoyant. My HDL is 60. My triglycerides are 95. And all my other subfractions like HDL size, VLDL, all that good stuff, it's all great.
Okay.
My insulin resistance score is very low.
Okay.
And my HSCRP was 0.44.
Okay.
So my question is, with all of my good stuff being good and all of my bad stuff being bad, which one do I focus more on? Because I'll tell you, my LDL was 499.
Dang. Okay.
Yeah.
So how long have you here? Let's say, how old are you?
37. I'm male. I'm 6'2" and I weigh 160 pounds.
So when we're considering cholesterol, we're considering more than just the numbers. We're looking at the full you as a whole human being, personalizing our care, what we want to do in terms of preventing heart disease. So first I would look at how old you were when you first noticed you have high cholesterol.
The first time I got it checked, I think I was probably 34. So about 3 to 4 years ago is when I started getting my cholesterol checked, because I was working out, weightlifting, and I was eating just an insane amount of carbs because of my weightlifting regimen. I mean, I was at 500-600 carbs a day.
Mm-hmm.
And I mean, it shot my my bad numbers up and my good numbers down. And then that's when I went and did a bunch of research and I tried keto, and keto actually lowered my numbers and raised my good numbers. So, and then for whatever reason, I got on carnivore thinking it would be a great idea. And now these numbers are scaring me.
Mm-hmm. Okay. Can you tell me your family? So when I think of cholesterol, I think of it as something like the LDL, for example, especially the small particle ones. I think of it as a particle that causes inflammation. Mm-hmm. And inflammation is basically what causes coronary artery disease, or what causes plaquing is inflammation in the body. And cholesterol is one thing that causes the blood vessels to have a little bit of inflammation that can cause plaquing over time, which is why we care about it. If we have that in our blood system for a very long time, over the course of several years, we can start to develop plaquing and we can start to develop coronary artery disease. When we're risk scoring someone, when we're evaluating them for their risk of heart disease, we take into account the fact that you have this ability of the fact that the LDL is high and can cause inflammation. And then we look at things that can counteract that, like your HDL, and we look at your exercise regimen. We look at your blood pressure, your risk factors. And if you don't have hypertension, you don't have diabetes, you're not obese, these are things that will help you kind of counteract the little bit of inflammation that might be going on from your high LDL numbers. Another thing that we really have to look at is your family history of heart disease. So people who have a family history of heart disease, or, their mom had a heart attack in their 50s, or their dad had a heart attack in their 50s or 60s, then we start to get a little bit more aggressive in reducing their LDL, because if their family history is high in coronary artery disease, it means that they have a predilection, or their body has this environment that's favorable for creating plaques. So do you have a family history of heart disease?
Actually, I know that my father had a heart attack, but from what he said and what the doctor said, it's because of his own doing. He's a lifelong smoker, 3 packs a day. He has COPD, and the doctors attributed his heart attack directly to his smoking and unhealthy habits.
Sure. Okay.
My mother has type 2 diabetes, but again, my mom is severely overweight. She eats unbelievably unhealthy. She doesn't try to fix her numbers. She just depends on the medications that the doctor gives her. And so any family history of anything heart related to my family is kind of, I hate to say it, their own fault.
Yeah, I get what you're saying. I would, in my office, at least when I hear the story that you're giving me, for example, I tend to not chalk it up to lifestyle, because we can't really say that. So like we can and we can't. So you of course, if you have an unhealthy lifestyle, your risk of heart disease and diabetes and such is higher. you know, but there are ways for us to kind of hone in and see if you have a predilection towards, you know, a genetic predilection towards heart disease. That high sensitivity CRP that you got was one way that we kind of can sift through that. The fact that your number was negative, right?
Yeah, my CRP was 0.44.
I don't know if that's positive or not, because it depends on the lab, I think. Is that positive or negative according to the lab?
According to the lab, it's a range of I've actually got my labs pulled up right here.
Well, and rather than going right into the labs, because I want to make sure that we talk about things that are relevant also for everybody that's on the call today. I will say that there are like inflammatory markers like a CRP that we get that help us figure out whether we should hone in on your LDL or not. Because so the high sensitive CRP is one of them. There's something called the lipoprotein little a that's another marker.
Right.
Yes. And so when we sit down and we evaluate your cholesterol, it's a huge comprehensive evaluation. Your cholesterol on its own is kind of scary, honestly.
Right. Yeah.
And doesn't mean I would treat you with a statin, but it definitely means that I would want to check in with you on a regular basis. We might even do something like a calcium score as you get a little bit older, make sure that you're not, you know, creating calcium, creating plaque in those blood vessels, that our risk stratification is matching with what's going on in the blood vessels.
Now they did give me one of those. And I'm so sorry to interrupt. It's just I forgot to tell you, they did give me a CAC.
Yeah. So I mean, you're still pretty young. So I mean, I'm guessing it's negative.
It was 0.
Yeah, I'm not surprised. So I you know, it's around the age 50 or age 55, I think for me, where I would start to consider, okay, is our analysis of your blood work and your risk stratification really matching up to your blood vessels? That's when I would want to do a CAC or a CAC. But you know, if I were your cardiologist, I would say that's a really high LDL. Let's make sure that your liver, you don't get fatty liver disease. You know, there's a lot of other things that LDL can affect. But you know, from what you've told me, you don't have a lot of other risk factors for heart disease. So, you know, it's all about risk benefit. If the carnivorous diet is really you know, improving your quality of life for whatever reason that you're choosing to do that, you know, I think that what I could do is a cardiologist could work with you to try to keep you healthy as best as we can. If that kind of answers your question a little bit. It's yeah, does that help at all?
Oh, no, absolutely. You know, I've got my primary doctor, and you know, he's fantastic, and you know, this is very unfamiliar to him because he's not a specialist in cardiology or anything like that. The one cardiologist I did go to before the carnivore diet, my LDL was 181, and the first word out of his mouth was, "Why are you not on a statin?"
Okay,
And so
I see.
so
Yeah.
I was like, yeah. So
Yeah, if you need to be on a statin, that's a whole different question. You know, I see what you're saying. I would, you know, it would be cool if you wanted to see me in the office. We can have a pretty deep discussion, a deep dive in this. Not that I'm trying to get you in the office. It's more, this is interesting. You're right. And I don't think I have a great answer for you without really nosediving, taking a deep dive into all the data, and having a very thorough discussion with you about your goals of care, and then, you know, your quality of life, those types of things. I would take all that into account when having that conversation.
right. And I appreciate it. And I guess at the end, you know, my biggest question is you know, my bad levels are bad, my good levels are great. I am changing my diet back to, at the very least, the keto diet, or more of a paleo kind of deal, to get my numbers down. And, you know, do it for about 3 months and get my numbers rechecked. With my numbers being that high and my good numbers being good, I mean, I should be just fine in the next 3 months to adjust these numbers, you know, right? I mean, I guess that's what I'm asking.
I mean, your CAC score is 0. So yeah, yep. Yes.
Okay. All right. Look, I can't tell you how much I appreciate your time.
Of course, no problem. My pleasure.
Thank you.
Of course.
Good evening, Dr. Nexad.
Hi.
Hi. Can you explain to us what is the difference between a doctor of osteopathic medicine versus just a regular cardiologist?
Yes. Is this Miss Mims?
It is.
Hi, Miss Mims. Good evening.
Good evening.
Thank you for your question. So doctors of osteopathy and MDs. So I'm a DO. I'm an osteopathic physician, and then there are people who have MD behind their name, who are my colleagues, and we are licensed the same. We have different exams in medical school, but then our exams afterwards then merge, where my cardiology exam, for example, my certification is the same as theirs, and we practice in the United States exactly the same. I'm a medical doctor, but just a different type of degree, and they're also medical doctors. I do procedures, all of that, prescribe medications, same thing. The only difference is they really pounded in our brains during training that we have to look at the whole patient. We can't just see them as an algorithmic kind of, they have this problem and this is the one solution. And so instead, someone comes to us and they have back pain, and we were trained to ask them more deeply about the pain. And sometimes, we will pull out of them that they've been kind of sedentary. They haven't been moving much. That's why they have back pain. And then they'll tell you that they're depressed. And then, we're supposed to create a conversation and not just focus on the pain itself and give them an opioid, for example. We were trained also to use our hands. So we're supposed to touch the patient. We're supposed to examine them if they have pain points. This is mostly for musculoskeletal discomfort. I don't do this personally in my office because it's been so long that I did anything with my hands like that I wouldn't be useful. But we have extra training in how to try to manage pain with something called muscle energy technique, where it's almost like chiropractic medicine, but not exactly the same, where we try to relieve pain with different exercises and different things that we do in the office rather than just pain medications. So that's a big part of it. But yeah, I think for us, what I hear is that we get recognized for the way that we talk to patients, because in our training, we're taught to be very empathetic and to really listen to the patient. That was just a big part of our training, because I think the medical community prior to osteopathic physicians coming in were not seen as very warm or very compassionate. There's a kind of a disconnect between patient and physician. And so osteopathy came in, the kind of changed it up a little bit so that the patient can feel like we are treating them in full. Does that make some sense?
Yes, thank you. And I have another question. Can you explain to us the difference between the various irregular heart rhythms that people experience, i.e., atrial fibrillation, tachycardia, and I know there's a third one. Can you explain what the difference is in those irregular heartbeats?
Absolutely. This is I appreciate your questions, Ms. Mims. This is one of a common complaint that I get in my office is palpitations. So tachycardia is just when the heart is fast. It's usually when we go for a run or we start walking real fast or we go up a flight of stairs, our heart will respond and it will beat faster than average resting rate. That is tachycardia, and it's not considered anything irregular, nothing typically that we have to treat. It's just tachycardia is really just describing a heart rate. If it's fast, it's tachycardic. And then there's bradycardia, which is a slower heart rate, slower than our resting heart rate. So there's normal, there's tachycardic, and there's bradycardic. And then a lot of people come into my office complaining of palpitations. Sometimes our heart will beat extra, like an extra beat from the top chamber of the heart or an extra couple of beats from the bottom chamber of the heart. And it will make people feel kind of like a little short of breath for a second or two, or they might feel a little bit lightheaded, but it's very brief for a second or two. Those are very common. They usually don't mean anything. They usually don't signify a sick heart, and there's nothing that we do about that. If you came into my office for it, I would work you up. We would make sure that that's what it was by putting a heart monitor on. But typically, there's nothing that we do about those irregular heartbeats, which are the extra beats here and there, that can happen even, for example, when we're a little over caffeinated. But there are a demographic or a group of people that come in that have extra beats throughout the day. They feel erratic and irregular, and they come on spontaneously, or sometimes they will happen for a reason, like they're exerting themselves. And when we put the monitor on, we look for something called atrial fibrillation, or AFib, which is an irregular heart rhythm. It's not lethal. It's not like a heart attack or anything like that, but we worry about it. And you probably see a lot of commercials about it on TV, because certain people who have atrial fibrillation are at an increased risk of stroke. So that irregular heart rhythm will put those demographic of people at an increased risk of stroke. And then to combat that risk, we put them on blood thinners. That's why we see these commercials for Eliquis and for Xarelto, to protect people who have AFib from stroke. And then we have very dangerous rhythms that people have defibrillators in their chest because of those rhythms. That's like ventricular tachycardia or ventricular fibrillation are a couple of examples of those. People who have heart attacks can have very dangerous rhythms later. It's not just heart attacks. People who also have weak heart muscles, they can have very dangerous rhythms. That's also what we look for when we put heart monitors on. And those rhythms can cause us to pass out, and it can cause the heart to stop, which is why you have, people that are walking around with defibrillators in their chest. Any other heart rhythms, Ms. Mims, you can think of?
No, I think you covered them all. Thank you.
Thank you.
Dr. Dexard, because we also cater to a younger audience as well, we want to provide some basic information, if you could do that for us, so we can, talk about how to unlearn some of those practices kind of passed down from generation to generation. Some of the questions that I've received, can you talk about how family history affects heart health?
Yes. Family history is a very big risk factor when it comes to coronary artery disease. It can get a little bit confusing, or heart disease, I should say. It can get a little confusing nowadays because people are kind of causing a little bit of harm to their bodies with overeating, not eating the right foods, not really moving much. And so it is really hard for young folk to differentiate between, is my mom and dad sick because of lifestyle decisions, or are they sick because of genetics? I do think that people in their 20s, when you say kids, do you mean people in their 20s, or do you mean kids?
Just generalized, starting from teenagers.
Okay. So I do think that when y'all see your doctors, it is worth asking to get a cholesterol panel. I do think that cholesterol gets overlooked in the younger population because there's this assumption that young people are healthy. The cholesterol is a little elevated, it's not a big deal. But kind of like we talked about before, cholesterol causes inflammation over time. So if you're 18 years old and your cholesterol is a little high, then that means that it'll be high. If it's genetic, it's going to be high almost every time you get it checked. And that's the type of high cholesterol I'm talking about. I'm talking about genetic predispositions. So if it's high at 18 a little bit, it's going to be high at 19, 20, 21. And then your blood vessels are just getting hit with that elevated cholesterol for the first 10, 15 years of your life, which means that you might start developing disease early, actually, maybe even in your 30s. If we did a scan in your chest, that those population of people might have plaque already in their blood vessels. And those are things that we can prevent if it's caught early enough. So I would not ignore abnormal labs or blood markers just because we're young. I think that that's just kind of a a misunderstanding, which I get, but it's not only that. So that's a blood marker. The cholesterol is a blood marker, but that also goes for obesity. Being a little bit overweight or just overweight is also inflammatory to the body, which is why it's a reason for the development of heart disease. Obesity is one of the main causes. High cholesterol is. Sugar hits, so like diabetes especially, but also a high sugar diet. Every time our blood vessels have a lot of sugar inside of them because of what we ingest, we eat the sugary food, the blood vessels get a bunch of sugar in them. That sugar is inflammatory if it's really high levels, which is why diabetes causes heart disease. So, you know, avoiding a high sugar diet, a high carb diet at a young age, trying to get into good healthy habits will prevent us from getting heart disease early in our life, in our 40s and our 50s, which is when it would show up. So let's not ignore blood markers like high cholesterol. I wouldn't also ignore high blood pressure. So I get a lot of people in my office whose blood pressures are in the 140s, and they're so comfortable with that, or 150s seems, everybody seems to know that's high, but I find that 140 seems to be an acceptable number, but it's really not. It dramatically increases our risk of heart disease. So if I see a 20-year-old with their blood pressure in the 130s, I get worried about that too. And I opt to, I tell them exercise, lose weight, let's recheck in 6 months. I definitely do not say, I don't let it go, basically, because there's objectively, they can develop heart disease sooner than someone who has normal blood pressure. Normal blood pressure being less than 120/80. That is normal blood pressure. Elevated is 120 to 130/80. And there is a difference between having blood pressure that is normal and blood pressure in the 120s, which is elevated. There's a difference in your risk of heart disease as you get older. Even that little difference, studies have shown, makes a big difference. So blood pressure being normal is important. Cholesterol being normal is important as best as we can. Weight loss, or at least being normal weight at a young age, is important. And then developing healthy habits so we don't develop diabetes when we get older, because diabetes is one of the biggest risk factors for heart disease. Having diabetes for about 10 years, is the equivalent as having a heart attack. A type 2 diabetes, type 1 diabetes, having it for 20 years is the equivalent of having a heart attack. What that means is that in 20 years of having type 1 diabetes or 10 years of having type 2, the heart has developed enough disease that it's as compromised as someone who has had a heart attack, which is why people who have diabetes, we like to put them on statins or cholesterol-lowering medications. And sometimes we will add aspirin because of their risk it's higher than the general population. So developing healthy habits young so that you don't develop diabetes when you get older is really important. And then the last thing is smoking. Just don't do it. If it's so hard to quit, I don't know that I don't smoke. Thankfully, I don't blame anyone that got into it, because there's so many different reasons why, but thankfully I never grew up around people that smoked. So, but I see it in my office that people have such a hard time quitting nicotine. I feel for them because there isn't a lot of great options out there, and addiction is difficult to get over. I know I'm rambling on, but this is what I do in my office, is preventative health. So I get excited about this part. The one last thing I'll talk about is alcohol. I think it is underestimated how damaging alcohol is. I think because culturally it's so socially accepted, but when at a young age, it was when we developed these habits, and we don't really think about how it's going to affect us when we get older. But I have a lot of people in my office that are having a lot of difficulty laying off the alcohol. And alcohol raises our blood pressure. Alcohol is very fatty. It raises our cholesterol. It causes us to gain weight. It causes very poor sleep. And when we're not sleeping, our body is inflamed. It can cause heart disease. So we need that rest state of sleep. We need to, not have that poison in our body. So just developing healthy habits and paying attention to the numbers, going and seeing the doctor, those are really important things for the prevention of heart disease.
Thank you. Thank you for answering that. I've also, one of the other questions that I received going back to diabetes was about diabetes in children. When do you start testing for diabetes in children? I've noticed that there's been a spike in children having diabetes and high blood pressure, mostly because they are overweight. However, there are some instances where you don't have to be overweight and still get diabetes. Can you talk a little bit about that?
Yes. Well, kind of. I don't actually know how old. I'm assuming that I don't actually know how old they start testing for diabetes, especially not before the age of 18. I assume that once people start having their physical, they get tested for diabetes, but I'm not entirely sure about that. All I know is, or what I can speak about, is that diabetes is a major risk factor for heart disease, so it needs to be taken seriously. Being overweight can increase our risk of insulin resistance, which is what type 2 diabetes is, but that is not, it's not a 1-to-1 ratio. So yes, you can be thin, you can, like they say, you can look healthy on the outside but be unhealthy on the inside. I see that all the time. So if you know, for people who look healthy on the outside, they're not overweight, for example, culturally speaking, they look healthy from the outside, they should still see doctors. They should not assume that they're doing, you know, they're well because, you know, they're not obese or whatever. They could still very well have diabetes. But in terms of what age, I'm not entirely sure, but from what I'm seeing in my office, it's probably never too early.
Perfect. Thank you. We have a question in the chat from Natalie Kramer. I am a lifelong migraine sufferer and was started on CGRP blockers in 2018. I believe that these medications have affected my heart rhythm. I have some debilitating symptoms. How do I find a cardiologist or an electrophysiologist knowledgeable in CGRP suppression and its effects on the heart? The cardiologist I have seen refer me back to the headache specialist, who refer me back to the cardiologist.
Oh boy. Yeah. This is embarrassing, but what is CGRP? I don't know.
Natalie, are you able to answer what CGRP is?
Look it up too.
It is calcitone gene-related peptide receptor.
It's a difficult question because, well, first of all, I'm not familiar with this, but it kind of depends on what it is that the arrhythmia is in the chest. I think that, yeah, I really don't know how to answer that. I think seeing the general cardiologist, hopefully they put a monitor on you. They were able to catch the rhythm. Usually these little monitors have triggers on them. So when you're feeling a certain way, you can push the button and the cardiologist can see what heart rhythm, you know, is whatever's going on in your chest. They can see that and compare it to your symptoms. And then use that information to make an educated diagnosis and treatment plan. I'm not really sure what, I don't know. And then, like, for example, for me, if you were having symptoms and I didn't know what to do, or I had reached my capacity, I would send you to an EP specialist for a second opinion. But yeah, I think without knowing exactly what it is, unless you wouldn't mind sharing that with us, it's up to you. I'm not really sure.
Natalie, if you would like to unmute to give further instruction or clarification.
Can you hear me?
Hi, yes.
Yeah, okay, well, thank you very much. Yeah, CGRPs, you know, they're fairly newly discovered, and these drugs are fairly new, and this is why it's happening. And, you know, it's just kind of frustrating because anyway, but you did answer my question, so thank you.
I did? Okay. All right.
All right, thank you.
Yeah, of course. I'm sorry. Yeah, I'm sorry that it's so frustrating. It sounds frustrating. Hopefully we can get to the bottom of it.
Well, CGRPs, they play a role in the headache mechanism, but they're also widespread throughout the body, and they play a role in other mechanisms, in particular vasoconstriction and vasodilation and things like that. And when you suppress them partially, some people react the way I do. It's not uncommon. And yet, you know, when you see a specialist, they pretty much toss you around, tell you to go see the other specialist. No, it's not me. No, it's without even taking much of a medical history. That's what,
Okay.
you know, I think there's a general fear of the unknown. And so the patient is tossed about and pretty much left to his or her own devices.
I'm sorry. That's, yeah, I understand what you're saying. I'm following your story. And I would be very frustrated too. But I don't know if I'm allowed to say this, but you can come and see me if you'd like to. And we could try to get to the bottom of it. I'd be happy to talk.
I'll look into that. All right. Thank you very much.
Thank you.
You're very helpful. Thank you.
Dr. Nexar, can you talk about how gender and race affect heart disease?
Yes. There's so much. So with gender, just generically, the male gender has a high risk of heart disease. I find that, so there's a high risk of heart attacks. For that reason, we are, a little bit more aggressive when I see patients who have high blood pressure, high cholesterol, diabetes, and they're men, especially Black men, because they are at higher risk as well, which is the majority of my patients are African American. I'm a lot more, I kind of scare them a little bit because the risk is higher. So we would have to be a little bit more aggressive with them. So men have a higher risk of heart disease than women. Women, I'm seeing, have a lot of palpitations. So women have a lot of fluttering in their chest, and it does seem to be associated with our cycles. So when we are menstruating, we will have more palpitations. And in my patient population, which are usually people over the age of 50, I'm seeing women go through menopause and they are really struggling with palpitations, and there's not a lot of answers for them, and they're extremely frustrated. And so I got a lot of those patients in my office too, and I work with them to try to calm that heart down so that at the very least, while there's so many other symptoms that they have with their menopause, but at least we can kind of soothe the heart muscle. I would say those are some of the big differences between the genders. The African American or Black population has hypertension. They have it from a young age, a lot of them that I see in my office, and sometimes it's very difficult to manage, but we work together until we get it down. And they get frustrated because they're telling me that they're not doing anything wrong. Sometimes they're eating low salt diets, they're being as healthy as they can, but just genetically speaking, without medication, sometimes there's no way of getting that blood pressure down. I also find that my African American or Black population are a little bit salt sensitive compared to the white population, and that's what studies show as well. So that means that if if they have like a higher salt load at dinner, the next day their pressure will be high. Their blood pressure responds and goes high with the salt load and stays that way for a while. Sometimes it can be difficult to get it down after that. So for them, the good news is that a low sodium diet then works well to decrease their blood pressure. Whereas in my white or non-Black patients, you know, a low sodium intake doesn't really change their pressure that much. I would say those are the biggest differences that I see in my office between races and gender. And then like the Indian, South Asian, my people kind of population have terrible heart disease. They I don't know if anyone's online that are from my part of the world. I don't see a lot of them in my office, but they end up having triple vessel disease, or they need open heart surgery in their 50s and 60s. So if I get that population in my office, if I see that type of patient, we're having a really serious discussion about prevention.
Can you also talk about what is considered a healthy BMI in both the African American and non-African American populations?
That's a really tricky one. If I'm being honest also with this one, I'm not super well versed, and I do feel like the data has changed since I was in school. We were using BMIs, and I think that the experts, or like the obesity medicine folk, are moving a little bit away from BMI, and they're actually going more and more towards something called body fat composition, which is it's like a scan that you can get. I think anyone can get that scan, and it will tell you your body fat composition. And then there are thresholds that if you're higher than that, then you have more fat. You're considered obese. So BMI, technically, I think normal is like less than 27, and then you get into overweight, and then obese is over 30, but it's different per race, it's different per gender. And I don't tend to like to use it in my office because it typically doesn't seem to match up with the person sitting in front of me. And that is also very frustrating for them. But yeah, I think body fat composition is the direction things are going towards. I don't know where you can get those scans. I would say ask primary care and see if they can kind of guide you. But I think that that's really good information to know. So I might even try to get something like that in my office, because it is very useful to know, you know, where we land on the obesity scale.
You discuss smoking and alcohol and overeating. We know that sometimes stress encourages those coping mechanisms. Can you talk a little bit about stress and anxiety and how that increases the risk of heart complications?
Oh boy, yeah. Yeah. So I come across so many people in my office that have stress and that have anxiety. They'll come to me with chest pain. They'll come to me with a complaint, whatever it may be. And then after 10, 15 minutes of explaining and talking about it, they'll just say, you know what? I think I'm just stressed. I think I'm just anxious. And I think it's something that's very difficult to manage, especially with our lifestyle and how much people have to work and, you know, taking care of kids and all of that. So I feel for people, but one way of managing stress and anxiety is exercise. I do try to tell people to try to fit in maybe 20, 30 minutes of walking most days out of the week. Get out there, put your headphones in, kind of get some you time. Just force it in there, almost like medication. If you can, tell your family, hey, like I got to check out for a little bit and go for a walk. It will increase endorphins. It'll lower your blood pressure. It's just good. And will put you into a resting state later when you are trying to sleep. Sleep is actually another big one that I try to address with people. I think that one thing that is underdiagnosed in the office, it's not just me who thinks that, but it is underdiagnosed, is sleep apnea. A lot of people stop breathing when they sleep and they don't know it. So if anyone on the line, you know, has a lot of trouble sleeping, they feel like they're in bed rolling around the next day, they're really tired, and this keeps happening to them, I would get a sleep study. If we're not sleeping well, it increases our levels of stress. Just biologically, it increases our stress hormones. It increases our level of anxiety, and it causes us to do things like overeating. Where, you know, when we're not sleeping, we are in survival mode when we're awake. because we're tired. The body needs to rest. And so it's trying to work for us, but it's very, very tired. And the way that it's telling us to, stay awake is by causing us to be hungry. So we eat, we overeat. It also becomes very difficult to lose weight when we're not sleeping well. So sleep is a really big, important part of a healthy lifestyle. So sleep, exercise, and then some people just have underlying anxiety. It tends to be just something they're born with. It's part of their genetic makeup. There's no shame in asking for something from your doctors to help you. I'm super against addictive medications. So I would recommend against Xanax and things like that, unless you have to, but there are wonderful antidepressants, anti-anxiety medications that kind of soothe you in a way where you don't even know it's happening. It's just 3 weeks later, you notice you're less, anxious. You're not sitting there in bed awake, unable to sleep because this medication has started to kick in. It doesn't change your personality, nothing like that. So yeah, I wouldn't be ashamed or afraid to ask for help if you need it for anxiety, depression, or stress. Make sure you get good sleep and see if you can get outside, or when it gets cold, somewhere safe, on a treadmill, maybe start walking, move your body. That will help.
And before we close out, can you just provide us with a few guidelines for maintaining a heart-healthy lifestyle?
Sure. So adequate sleep, I would say, is really important. Making sure you try to eat a heart-healthy diet. So the heart-healthy diet that I recommend, that the Heart Association recommends, it's on the American Heart Association, AHA's website, called the Mediterranean diet. So if you type in AHA Mediterranean diet, it will take you right to the page, and you can kind of read about the heart healthy diet. It's full of foods that are going to cause kind of an anti-inflammatory environment in the body to prevent heart disease from forming. It's also a cholesterol reducing diet. It's high in fats, but it's high in good fats, and it's shown to reduce cholesterol. So the Mediterranean diet is the diet of choice. Exercising, the Heart Association recommends 150 minutes of exercise per week. So I tell people 30 minutes most days out of the week, 30 minutes in a row of cardio. So anything that gets the heart rate up a little bit is what we're asking for. And you want to do that for 30 minutes in a row, 5 days out of the week. And that is going to not only help you with stress and anxiety, it will help you with sleeping. It will help you hopefully lose a little bit of weight. But if anything, it will help keep your blood pressure normal. And it will help with insulin resistance, prevention of insulin resistance or diabetes. So physical activity, super important. And then just staying away from drugs would be the last thing.
Does anyone else have any other questions for Dr. Nexard? And how can we reach you?
I'm going to say one more thing before we talk about that.
Yep.
Also, I think I want to, one thing that I see in my office is, I think that all of this is really hard. People are struggling with how to be healthy. And so a little bit of self-compassion is important too, and asking questions. It's really easy for me to be up here and be like, oh, Mediterranean diet, do this and do that. But I do think it's really, really hard. And there's relapses. Like people will do well for 2 weeks and then relapse, or 2 months. And that's okay. It's progress, not perfection. And we're here to support you as your doctors. That's the last thing. In terms of reaching me, my office number, I have that. You want me to share my office number? Yeah. Okay, so office number is 301-782-2220. And that's to schedule an appointment with me. I would love to see you and we can have a conversation. I think that's the only way to reach me. And I mean, I'm online too, I think, right? I don't know.
We have one other question in the chat. It says, can you explain triglycerides?
So triglycerides are a type of cholesterol that can have adverse effects also on things like the heart as well as the liver. It is related to what we eat, especially processed food, oily food, certain types of oils. So I'm sure, you know, extra virgin olive oil is heart friendly, but all the other ones are not, and they will increase things like triglycerides. Just like any other cholesterol number, like LDL, we have a number, a target for triglycerides that we want to maintain under. So just like LDL, triglycerides are inflammatory. They are one of the bad cholesterols like LDL, and they can cause heart disease. So if they're high, the first recommendation I always make is changing the diet, because it's very much related to diet. But if we notice it's not, not manageable by dietary changes or whatever it may be, then typical cholesterol lowering medications will help reduce triglycerides, like statins, for example.
Okay. And if there are no other questions, I can close this out. So thank you so much for that insightful presentation on maintaining heart health and offering those guidelines for maintaining a healthy lifestyle. We hope that all of you found this presentation helpful. As always, a big thank you to Centerpoint and the phenomenal MedStar team for your collaboration on this important initiative, and to all of you for joining us. To get the replay or to share this presentation, please visit any of our Facebook and YouTube pages. We hope that you will join us next month for another installment of our Ask a Doctor series, where we will ask the spine surgeon. Thank you all and enjoy your evening.
Thank you. Thank you so much.
Thank you.
Bye.